Hello, my name is Karuniawati. I'm clinical microbiologist, and my lecture today is about the microbiology laboratory and antimicrobial stewardship program, focus on interpretation of results and antibiogram. So, as we know that the microbiology laboratories have a very important roles in the antimicrobial stewardship program. There are some roles they have to play, but now I want to emphasize two the most important roles in the stewardship program. There are cumulative antimicrobial susceptibility reports, or we usually name it as antibiogram, and enhancing the culture and susceptibility report so that our research can be used by the clinician correctly. We have two important investigation in the microbiology laboratory. First, for diagnostic. So we will get two important results. First is the species or the identification of the microbes, and of course there will be proceeded to the susceptibility testing, which is very important first for determine the definitive therapy for a particular patient, and the cumulative result of this susceptibility testing can be collected and reported as an antibiogram, which is very important as a reference, as a evidence-based data to determine the empirical therapy. And this, of course, will lead to the stewardship of the antimicrobial therapy. On the other side, microbiology investigation is also very important for screening. So, especially for patients who are admitted to the hospital, should be screened whether the body of the patient are colonized with multi-drug resistant organism. So, if yes, then we have to perform the transmission precaution, and this is actually one of the practice of infection prevention control to avoid or to prevent the spread of the multi-drug resistant organism. As we know, in the past 20 years, I think there are so many new instruments, from the semi-automatic until the automatic ones are developed in the market. And we as clinical microbiologists, of course, have to decide which one is the best, and also how to use it optimally. But of course, also that we have to know that the result of microbiology investigation or examination is not just a result that can be directly delivered to the clinician. We have to interpret this result, even though it is a genomic automatization or proteomic result. It is very important to be interpreted, and because we have to collect to interpret this depend on the clinical sign and symptoms, and also other biomarkers which are very important in decide whether this particular microbes are actually involved in the infectious disease or pathogen. In the clinical setting, the goal of the interpretation is to get the correct diagnosis of the infectious disease and appropriate treatment for the patient. And that's why the choice of the technologies should be based on these two important factors. Will this result from the new technology give positive impact subsequent patient care? And of course, the next is that this technology result in cost avoidance downstream. The total test process in the laboratory, so not only in the microbiology laboratory, of course, there are three main phases: pre-analytical, analytical, and also post-analytical phases. And these three are very important. The pre-analytical is when the doctor decides to send the samples of the patient to the laboratory, and also the choice of the samples, the transportation, and the screening of these samples in the laboratory, the screening about the quality of the specimen or samples. And about the choice of the samples, this is sometimes that clinician need to discuss it with the person in charge in the laboratory, because we have to choose the right specimen and also the right method that can be done for this patient, for this patient samples. So between these three phases, actually the pre-analytical can contribute the most, or can contribute very much in the error of the result. So from some literature reported that pre-analytical phase may contribute until 68% in producing an error result. And the analytical is less, because usually in the analytical phases, the laboratory has already doing the internal quality control, external quality control, and quality assurance in general. So this is also important as one of the three phases, but the quality can be controlled better than the other one, than the pre-analytical and post-analytical. Post-analytical is when the result is written on the paper and then interpreted, and also the microbiologist will give expertise and then send it to the doctor. And it is also important that the expertise or the interpretation will be the same made by the doctors. So this is also very important, so that the choice of antibiotic or other management of patient really the same as what the clinical microbiologists think. So if the sample delivered to the laboratory, then there are two kind of test algorithm can be done. First is the conventional method, which maybe take longer time. For example, if we do the culture and then antimicrobial susceptibility test, then it can be finished in maybe 3 or 5 days. But in between, actually, we can do also rapid diagnostic tests. For example, if a patient with community-acquired pneumonia, then we can also do or collect the urine sample to be tested using the immunoassay to detect the antigen of Streptococcus pneumoniae or Legionella pneumophila. But parallelly, there is also culture of sputum samples, and this rapid test will help the doctors very much. So if usually the immunoassay will be finished only in 1 hour, maybe in total, and this result can be directly delivered to the doctors with notice, of course, that this is a rapid test, and the antimicrobial susceptibility test is still being done in the laboratory, and the result will be in 2 or 3 days after the rapid test is finished. So that's why in 1 hour, I think the clinician can give the empirical therapy, and then wait until the antimicrobial susceptibility test finish. When we get the result of culture or identification, then we have to decide or to determine whether this bacteria is pathogen or non-pathogen. So it is not really easy to decide, but there are 4 things that we have to think. The first is the origin of the specimen and evidence base of pathogen as the etiology. So, for example, if we examine the fecal samples, and then the result of the culture is, for example, Klebsiella pneumoniae, then of course we will not report this Klebsiella pneumoniae as the pathogen of the diarrhea. Or also if there is a pharyngitis, and then we get the throat swab and the result is Streptococcus pneumoniae, even though it is actually pathogen for other organ, but not for pharynx or pharyngitis. So that's why in that condition we will not report Strep pneumoniae as the etiology of the pharyngitis. And the second one, if we get the polymicrobial result, for example, from blood, then we need to check it again, whether it is actually contaminated, or we can also discuss with the doctor that maybe the sepsis patients have more than one sources of infection. So they have to check, maybe, for example, from the pneumonia, from the lung, and also then we can report our result. But please very careful in interpreting the polymicrobial result. The third one is the host immunology status. As I said before, when we get Streptococcus pneumoniae from the throat swab, it is not the etiology of the pharyngitis, but in host, if the patient has the immunodeficiency, then we need to analyze it and discuss with the clinician, because it can be a critical colonization, and we have to decide together whether this patient has to be treated with antibiotic or not. The epidemiology is also very important. The local, of course, the local epidemiology, because so it is also important to decide whether it will be identified or as a target of a pathogen that should be detected. So some of area maybe they don't have any epidemiology data, so that's why actually also our task to have this kind of data, because it will also help the clinician in making the diagnosis. So between contamination, colonization, and infection should be interpreted when once we get the microbes. It can be bacteria or maybe fungi, yeah. And what is the contamination? This is the growing organism that are not from the intended site culture. So for example, if we culture the blood specimen and Streptococcus epidermidis is the organism that grow from the medium, then we have to consider it so 50% as the contamination from the skin, or it can be also the pathogen, for example, from the blood slip infection or catheter-associated infection. So usually, if we have two samples, blood samples, which are taken from the different sites, and both are Staphylococcus epidermidis growth from this both sides, then the positivity of this as a pathogen will be higher than if we have only one blood specimen. Colonization is the growing organisms that are unlikely to cause infection, or growing organisms without sign of infection. So, for example, as I explained before, if we get Klebsiella pneumoniae in the diarrhea patient or in just in fecal samples, it is a colonization. First, because it is a normal flora, there is no sign of infection, or in diarrhea patient, it is also not as a pathogen because evidence-based there is no diarrhea which caused by Klebsiella pneumoniae. Infections is the presence of multiplying bacteria that overwhelms the patient's immune system and result in bacterial spreading. So there is sign and symptoms of the disease. So when the laboratory get the samples, then normally we will do the gram stain from the direct specimen. This is very important. First is to know the quality of the specimen, and also maybe from the sterile site we can predict the pathogen to see the morphology, gram positive or gram negative, coccus or bacilli, and we can inform this morphology to the doctor to narrowing the antibiotic use in as an empirical therapy. We have to remember that the sensitivity or the limit detection limit of gram stain is 10 to the 5th set. That's why if the cells, bacterial cells less than 10 to the 5th, we cannot see the cells on the specimen under microscope. So that's why the false gram stain result may be related to first the not adequate collected specimen, or maybe it is also that the number of bacteria less than to the 5 cells per miles. So sputum culture are usually the most specimen we get in the hospital. So after blood samples, maybe. And this is actually very common and so difficult to interpret because sputum should go through the upper respiratory tract, which consists of many normal flora, and strep pneumoniae and or Haemophilus influenzae both are normal flora that can make our result false positive in the patient with carriage or carrier of these two organisms. So we have to be very careful in interpreting the positive culture on sputum with strep pneumoniae and Haemophilus influenzae. So there are some specimens that can be used, like bronchoalveolar lavage and also protected specimen brush. But we know that if we use the lower respiratory tract secrets, then we have to do the quantification. And in this box is the information about the sensitivity and specificity of the quantification of these both samples. This is an old reference, but I think it is very important to know that the sensitivity and specificity, so the range of this are very wide. So that's why need to be interpreted carefully. So after we got the pathogen, then we will proceed to the susceptibility testing. And of course, we have to consider this 4 things that are very important to decide whether this pathogen will be proceeded to the susceptibility test or not. The very important one is also the well-standardized method is available in the laboratory. So for example, vancomycin and polymyxin cannot be done or cannot be tested using this diffusion or using the semi-automatic machine. So that's why we have to do the microdilution to determine the susceptibility of vancomycin and polymyxin. So please be aware of these 2 antibiotics. So in the interpretation of the culture and antimicrobial susceptibility test, it is not just simple as we see here. So this is Klebsiella with this susceptibility. We have to understand some point here is that it is actually really a good result. So the combination of this susceptibility test is also very important to know because sometimes if the results say that it is inconsistent, it means that it is not this combination of susceptibility test is not found in the database of this semi-automatic machine. So that's why we have to be careful, and maybe also in the laboratory we need to repeat this test, this antimicrobial susceptibility test. So there are 3 most important considerations in interpreting the result of antimicrobial susceptibility test. The unusual result of exceptional resistant phenotype should be recognized. So for example, for Staphylococcus aureus, if you find that it is resistant to vancomycin, then we should be aware whether it is a good or correct result or not. So that's why it will be better if you repeat the test, because it is actually not from the epidemiology point of view, the vancomycin resistant Staphylococcus aureus is very, very rare. The intrinsic resistance is also very important. For example, Pseudomonas aeruginosa has the intrinsic resistance against ceftriaxone. So that's why we don't need to report it, even though, for example, the result of this diffusion is susceptible. And the third one, also the interpretative reading and expert rules resistant as a marker. So for example, in the MRSA, we know that we cannot use other beta-lactam antibiotic, with the exception, of course, the ceftaroline, which is the only beta-lactam that can or have the spectrum to MRSA. So this is all factors that we have to consider. Yeah, so this interpretation is of course always change. So please always update it, the interpretation of the susceptibility test in our standard. So if we can use CLSI or UCAS to update our knowledge about this. Minimum inhibitory concentration is also very important. So we will get it from our semi-automatic result, or maybe if you use the microdilution method to test the susceptibility. So this we know that this will also interfere the outcome of the patient, and that's why this MIC will lead us to decide the dose of the antibiotic, which one should be used. So is it a regular dose, higher dose, or maximum dose? So this is the example. If we use the cefepime as therapy, then how is the breakpoint of this result? So this is the if the cefepime breakpoint is susceptible, then we can use the normal dose. But if it is susceptible dose dependent, then we need to higher the dose. Or if it is actually in the border, then we have to use the maximum dose. So the cumulative antibiogram hospital, together with the hospital, the data of hospital associated infection and the surveillance of the or AMC, these three is very important in making the antibiotic policy in hospital. And of course, this as a baseline data also for the standard treatment guideline, and very important. So one of the most important document in implementing the antimicrobial stewardship. Yeah, so the antibiogram is not only data, but it can say many things. So it depends on us as a clinical microbiologist, together with the responsible clinician in antimicrobial stewardship program, to analyze this antibiogram. We know that the ideal antibiogram should come from the first isolates only. So when the patient admitted to the hospital, and then the specimen collected and then cultured, then this isolate is collected as or included in the antibiogram, because this data this collected data will be used in decide which antibiotic will be good for the empiric antibiotic. So in this patient, if in the middle of the hospitalization, maybe they should be collected again, then we don't use the result of this collected specimen for the antibiogram, because it will make a bias of our result. And then we can also grouping. So sometimes if we just start to make the antibiogram, then just make it for all hospital. But if we have many data, then we can grouping our data or stratify our data into this maybe acquisition of the infection between community and hospital, or the patient location, for example, from ICU, from the normal ward, or maybe from pediatric and adult, and also from the specimen side. Yeah, so this is also very important. So this is the example of antibiogram. This is the number of the isolate tested using this antibiotic. Yeah, we give all the abbreviation under the tables, and then we just put the percent of susceptibility, not the intermediate or the resistant percentage. And after we got the result, then we will review it together with other clinicians to identify the misleading or suspicious susceptibility information and assess the clinical appropriateness of the information provided. And from our reference, CLSI, we need minimally 30 isolate to be performed in this antibiogram. But if we have less than 30, but we think that this is very important species, then we can include with a notice. Yeah, and then for the antibiotic, also important that we report only the antimicrobials which are available in this hospital. Yeah, and if there is inconsistent, then we need to see our database again. Yeah, and of course, it is also a very good input for the next antibiogram for the next data. And this is also very important to be reviewed and before we distribute the antibiotic. So not only it is very important that this data is not the only data, but we have to make it for the easy to understand from the clinical side, so that the clinician can use this properly. So as a take-home messages, we know that microbiology has a very important role in fighting AMR problems, both in diagnostic and screening, and both can make the practice of antibiotic stewardship better, and also the infection prevention control to avoid the spreading of the resistant bacteria. And clinical microbiology is science of interpretative judgment. So please, we have to expertise to give the interpretation in the result. Error is mostly in the pre-analytical phase. So that's why we need to guide the clinician in choosing the specimen and also transport it to our laboratory. gram stain is crucial, and interpretation of susceptibility test is very important. So not just susceptible, intermediate, and resistant, but we need to interpret this according to the resistant mechanism. And MIC also can be used in the determining the dose of the drugs, the antibiotic given to the patients. So I think that's all my presentation. Thank you very much for the attention.